Let's round up this session. As I told you when we started, Dr. Hawes is an innovator in endoscopy, and so we thought that we would ask him to talk to us a little bit about endoscopic innovation and what's ahead for the future. So Rob, welcome back.
Great, Dave. Well, congratulations to David and Nikhil. They were excellent talks. I want to give you just a little bit of glimpse, if you will, into the future of endoscopy. And this is a difficult thing to talk about. If I asked 10 people to do this, you'd get 10 different takes on what's going to be happening. But I'll share with you what I think. The dynamics that will shape the future of endoscopy, I think, are included in this slide here. I think obviously what we do technically with endoscopy and innovation there, what will happen with healthcare and how that will change will shape what we do. And then there is always this concept of disruptive innovation, which I believe very strongly works in the field of medicine. So these are the dynamics that I think we're dealing with. The other dynamic that is on its way, not fully implemented, but will definitely shape the future of endoscopy is the death, if you will, of a fee-for-service kind of system. And I think that's going to be a very, very strong determinant of how we practice endoscopy in the future. When I think about the future of endoscopy, I cannot do so without separating diagnostic from therapeutic endoscopy. You can't take both of these and go forward. I think they are clearly, in my view, separated. And so that's the sort of the direction and the tack that I will take as I try to get a glimpse of the future. Diagnostic endoscopy is actually sort of a hard thing to make cost effective, at least the way we're doing it now. But I think early detection of neoplasia is one opportunity for diagnostic endoscopy to be cost effective. And then to be able to do something to get an accurate diagnosis and avoid other tests is another way that diagnostic endoscopy can be cost effective. If you look at diagnostic endoscopy, I think all of us and certainly healthcare providers need to figure out how to make it less expensive. So how can we make it effective and yet at a lower cost? Well, I think it'll come as a little bit of a surprise to you, but one way is to eliminate expensive endoscopists. So Carlock is a very expensive individual. He's got a very big lifestyle that he's got to maintain. And so he's costly. David is a costly endoscopist. I think sedation is also, sorry. Yeah, if you just get rid of Carlock, you probably don't go a long way to making it cost effective. No, eliminating sedation. I think sedation is a very big part. We're going the wrong direction with sedation. We've gone from sedation given by the endoscopist to sedation given by anesthesiologists or CRNAs. We can improve patient compliance. That will make it more cost effective. And then we can modify our technology. I'm a big believer in this concept of disruptive innovation. I believe that the theory, Clayton Christensen's theory of disruptive innovation does work as I conceive about the progress of endoscopy. And I think sort of in a nutshell, as you go over time, if you look on this axis, you have sort of performance of the product. Within these crosshatch areas, you have an acceptable performance for a particular product. But innovation always begins down here. It always begins as a technology that doesn't perform as well as standard technologies. And the key is to look at how it can be progressed. And when I view a new technology, I don't look at the efficacy or of that technology at the time that it's introduced to me. I try to conceive of iterations of that technology that will move it into a standard of care kind of situation. So if you look at disruption of endoscopy, I think one disruption that can occur and that gets at the cost of the endoscopists is actually a change in endoscopic providers. You look now at endoscopic providers being specialists and subspecialists like myself and David. There are primary care physicians doing endoscopy. And then you go down to nurse practitioners and maybe even to self-care in terms of endoscopy. And you can, this has been pioneered primarily in the UK, but this is a systematic review and meta-analysis looking at all of the papers that compare physician endoscopists to nurse endoscopists, and it breaks it down into flexible sigmoidoscopy, colonoscopy, and EGD. And in fact, there is no difference in the outcome parameters listed here between a qualified, trained nurse practitioner doing endoscopy and a physician doing endoscopy. So I think as we move ahead in healthcare, maybe those of us, physicians that are doing endoscopy, will be disrupted. It also predicts a change in the site of service. And we've already seen some of this. We've gone from a general teaching hospitals for endoscopy to outpatient clinics to in-office endoscopy, and maybe it will even go further. And the technology that will take this down is capsule endoscopy. And I show the existing capsules now, but this may not necessarily be the technology that is the end game. But it is this idea that you can actually get images from inside the gut, transfer them out, and do so without sedation, interpreted by somebody who is less costly than a physician. It can be real-time viewing. And the question is, can we do an adequate examination of the entire GI tract or part of the GI tract? And this has been a long time coming, but this is a recent publication from China comparing standard endoscopy with a magnetically driven capsule endoscope. And it was a multi-center study, again, done in China. The EGD, or the endoscopy, was the gold standard. And the results, at least the outcome, was detection of focal gastric lesions. And you can see here that the magnetically controlled capsule actually had a very high sensitivity and a very high specificity. But what I think you maybe need to look at is this, which is that it had a really, really high negative predictive value. And so this opens up the door, if you will, perhaps for people with dyspepsia, with mild symptoms that we know have a fairly low detection rate for significant pathology by standard endoscopy, and maybe in the future it will be done by capsule endoscopy. Right now, I use sort of GI oncology as sort of a surrogate marker for where we're going. And if you look at oncology, the steps that you want to satisfy are you need to stratify risk. That's the first thing that you need to do when you're looking at a population and you're looking at a particular cancer. You need to stratify risk. You can't screen and survey everybody in the population. You have to stratify risk. You then screen that population. Once you've stratified that group and you've got the high-risk group, that's the group that you need to screen. And then hopefully with that you detect early neoplasms, and then hopefully those early neoplasms can be managed in a minimally invasive way. Right now, diagnostic endoscopy is being used in these first parts of cancer detection, and then obviously therapeutic endoscopy is being used for the therapeutic realm. But in the future, I think it will be non-MDs and non-endoscopic means that will take care of the first two parts of this sequence of events to detect early neoplasms. And yet therapeutic endoscopy, I think, instead of shrinking, will in fact grow. But I think diagnostic endoscopy is going to be disrupted as we move forward. If you look at therapeutic endoscopy now, if you move to the therapeutic realm, there are actually, for me, easier ways to see how therapeutic endoscopy can be made cost effective. A primary principle is a move of the site of service. An operating room is a very expensive piece of real estate, and it's very expensive to run. And so moving the site of service to our endoscopy suites will go a long way to making it cost effective. Replacing surgery is another way, and then reducing hospital stay are all ways that I think that therapeutic endoscopy can be made cost effective. This is a study that we did at Florida Hospital. We took a group of patients that were matched for age and comorbidities, et cetera. And some of them were managed, their large benign colonic polyps were managed by endoscopy, and the other group were managed by surgery. And you can see here that if you look at the cost, the complication rate was lower for endoscopy, the hospital stay was lower for endoscopy, but very importantly, the cost was significantly lower for endoscopic removal of benign colon polyps than was surgery. The interesting thing and the conundrum that we have in our current healthcare system is that my therapeutic endoscopy was actually reimbursed at lower than the cost of doing the procedure, and yet surgery was reimbursed at 3 times the cost of doing surgery. So our hospital administrators, if there are any in the room, this is problematic. They love to fill their ORs, but this is not right for patients. And this will change when the fee-for-service changes and when our healthcare changes, and it will be a boon, if you will, for therapeutic endoscopy. This is a similar study done by Michael Burke in Australia, looking at a cost analysis of EMR versus surgery. And the bottom line is that you look here at the cost differential per patient was $7,600 between the cost savings per patient. And if you looked at, it was a reduction in hospital stays, et cetera. So out of this cohort of patients, they saved $10 million of real savings by treating patients endoscopically rather than surgically. And then if you look at our change in Barrett's, this is the latest study from Amsterdam looking at management of high-grade dysplasia and early carcinoma in Barrett's patients. And again, these were patients that uniformly went to surgery perhaps 10 years ago. Multifocal high-grade dysplasia, early mucosal cancer went to esophagectomy. And if you look at the combination of EMR combined with RFA to manage these patients, on an intention to treat, they had a 92% complete eradication of the neoplasia and almost a 90% complete eradication of IM. So we've taken a group of patients that uniformly would have gone to surgery and virtually taken care of virtually all of them. And so it's a huge paradigm shift from surgery to endoscopy, and I think highlights the value of therapeutic endoscopy. A real bugaboo for me is training. And as we move forward with these therapeutic modalities, one trip that we may fall into, or one trap that we may fall into, is training. And I've spoken now for quite some time on our training. I think that gastroenterology training needs to change. I think we need to do a better job of highlighting therapeutic endoscopy during a third-year fellowship. I don't think that we're training people well enough in therapeutic endoscopy in a standard 3-year program. I don't think it can be satisfied by the patchwork of advanced programs that are ongoing if you look globally across the entire United States. And so training is really, really important because if we fail, right now, failure is not counted against you because everybody gets paid. The patient loses, but everybody gets paid. If I fail at ERCP, I can repeat the ERCP. If I fail at the ERCP again, I can repeat the ERCP again, and everybody's getting paid on down the line. But that will not exist in the future. And this is, we looked at a large database, and we are in the process of publishing this data. But this is looking at the costs of failed hemostasis. And maybe David will get into this on his hemostasis thing at lunch. But if you look at median costs for the first endoscopy for hemostasis, it's about $10,000. If that patient has to go to another endoscopy, it's $20,000. If they have to go to interventional radiology to salvage that case, it goes to $34,000. And if they have to go to surgery, it goes up to $47,000. So our hemostasis rate should be in the range of 85 to 90% with our current modalities. But when we looked at our hospital system, we were nowhere near that rate. So I think it's something that we have to be cognizant of. If we move into therapeutic endoscopy, okay, replacing surgery, moving the site of service, but we fail at what we do so that it has to be repeated and repeated, then it's going to be very, very counterproductive. And the future is in this slide here. We are going to be becoming more and more aggressive and I think more and more successful at resection. David did a wonderful job of talking about submucosal surgery, and I feel that's just the tip of the iceberg with myotomy. There's so many other things that we can do in this submucosal space. That will be a big part of surgery. Nikhil has done a great job of talking about bariatrics. I think there is no question that endoscopic, therapeutic endoscopy will play a role in bariatrics in the ways that are listed there. And then finally, Nikhil didn't touch on it, but this idea of metabolic endoscopy I think is going to be a big deal. The data is very, very early, and it's very, very, very speculative, but there is a company called Fractal that is basically doing a submucosal injection into the duodenum, distal to the ampulla of Vater, and extending that to the ligament of Treitz, and then they're ablating the mucosa using a water-filled balloon, a hot water-filled balloon to ablate the mucosa. And the preliminary data suggests that it may be a very, very good treatment for type 2 diabetes, but some very, very, very preliminary data suggests that it actually may be a treatment for NASH. So I think this is very, very exciting stuff, and I think metabolic endoscopy may be another big thing of the future. Why are we progressing so rapidly? It's a great time. I sort of wish a little bit that I was in Nikhil's shoes, because I think that therapeutic endoscopy is now accelerating. It's accelerating really quite rapidly. And I think part of it is because we can better manage our own complications. I think that's given us some power to move forward in ways that we couldn't before. I think now, as endoscopists, we're fixing a lot of surgical problems. And in the past, it was always the surgeon. It was a one-way street. The surgeons were fixing our problems. I think the fact that the site of service is a cost savings is driving this, and then technology advances are also driving it. So we're in the midst of a spectrum of therapeutic endoscopy. We've had hemostasis and polyp resection for a while. We've now entered clearly the area of endoluminal therapy, obesity management, et cetera. David talked about submucosal surgery, and it'll go beyond all of his poems. There'll be drug delivery, probably a better study of motility disorders will be able to be made, et cetera, et cetera. And then finally, the issue of notes will come back. I think it's been poo-pooed as maybe never going to occur. But in fact, transanal colon resection using the anus as a natural orifice is actually gaining quite a bit of traction, as well as hernia repair. So I think the future is great, but the only sort of comments, or the final comments that I would make is that the dynamics are such that it is having a major effect in lowering reimbursement, and I think that's one thing that's driving the advancement of endoscopy. Right now, there's no adjustment for therapeutic endoscopy, but in the future, when a healthcare system employs somebody like Nikhil, they will look at the value to the savings of the system rather than just what he can extract from insurance companies in terms of reimbursement. We've got to change the training in GI, I think, to keep up with this. 3 years of general GI are not going to be enough to train people in these therapeutic things. We've got to stop the migration, I think, of gastroenterologists going purely into ambulatory endoscopy units doing diagnostic endoscopy, and we probably need to increase the number of gastroenterology trainees. So my conclusions are, with healthcare change, the best opportunity for endoscopists, I think, are going to be in the therapeutic realm. I think we need to develop specialty units, similar to what's being done here, that are best suited for today's healthcare environment. The optimal environment for this may not necessarily only be in purely academic environments. I think there are other environments that it can happen. And I think that therapeutic units must integrate hospital systems integrate with hospital systems that really measure the value of therapeutic endoscopy as a whole, as opposed to just a reimbursement kind of a scheme. So I think the future is bright, and I look forward to seeing what innovative things are done by the next generation of endoscopists. So I'll conclude with that. Thanks very much, David. Thanks for being here.